Welcome to ResearchMD.com. We got another great presentation today. My name is Pramil Cheriyath. I'm a physician. I'm a program director in internal medicine and transitional residency in the United States, director of research, and I'm also an assistant professor of medicine to large medical schools. So today our topic is, again, we continue our presentations of anemia. We started with microcytic anemia, then we went into macrocytic anemia. Today we're going to look at the normocytic hemolytic anemia. Okay, so we did hereditary spherocytosis, hereditary elliptocytosis. So today we're going to look at it, pyruvate kinase deficiency. Okay, so what is the first thing we always have to do? We start with our definition. Okay, so what is it? It's an autosomal recessive. It's an enzyme defect. Okay, most of the enzyme defects are autosomal recessive. So look at the definition again. You got an RBC enzyme disorder creating hemolysis picture. Okay, it's an intrinsic defect in the RBC enzyme, results in extravascular hemolysis, mainly in the spleen. And then what happens is you got PKLR gene mutation. That's also we need to remember. Okay, so that's why we just have to, when you do these investigations, we have to check for PKLR gene mutation. That's the test you can do to diagnose it. Okay, now epidemiology mainly affects the Caucasian, but there's some incidence more in the Middle East population, also 1 in 20,000 prevalence. And look at, when you look at the clinical pictures, very important to go back in the neonatal period. You can, extreme cases, it can happen in the utero, you can become hydrops fetalis, but you can, the mainly thing you have like neonatal jaundice, we treat with the phototherapy, and severe hemolytic anemia could be the picture. And then in the childhood, again, hemolysis, and you can have jaundice picture. Also, the splenomegaly is at least 45 to 50% of the people have like large spleen, and gallstones. And what kind of stones we can have in this people hemolysis?
Pigmented gallstones.
Pigmented gallstone. And are they sterile or unsterile?
Sterile.
Sterile. Okay, very good. Okay, in the adolescent, again, hemolysis, and you got the jaundice picture, and then you got splenomegaly. Of course, again, the pigmented gallstones are there. It can be exacerbated by stress, infection, and pregnancy. Sometimes in the pregnancy, it's like more common. It get like, and some people get even diagnosed in pregnancy. So it's very, very important to remember that. Okay, pregnancy. Okay, now let's go back to the RBC. What happened in the RBC? You need ATP. Okay, so you got glycolysis. That's what usually happens in the RBC because it doesn't have mitochondria. Remember? So let's look at this biochemical picture, like what happened in each level. Okay, let's start with the glucose. Glucose is converted to glucose 6-phosphate. You actually use ATP for this purpose, and then glucose 6-phosphate is converted into fructose 6-phosphate, and then fructose 1,6-biphosphonate, and then that's converted into glyceraldehyde 3-phosphate, which is converted into 1,3-biphosphoglycerate. That's converted into 3-phosphoglycerate, and then that's converted into 2-phosphoglycerate, and then you have phosphoenol pyruvate. That's converted into pyruvate. Okay, this is the main thing, is we need the enzyme. What is that? Pyruvate kinase. Okay, remember, this is the most important step. If you don't have the pyruvate kinase, right, this is the mutation happening. If you don't have this pyruvate kinase, main thing, ADP will now be converted into ATP, because ATP is needed for the sodium potassium ATPase to work. That can create the shape of the RBC and then result in what is called Burr cells or echinocytes. Okay, that is one of the peripheral meal diagnosis you need to know. Okay, so it's important over here. So the main step is phosphoenol pyruvate to convert to pyruvate, and this pyruvate kinase enzyme is lacking, so lack of ATP production, then sodium potassium ATPase not going to work, and the red cell membrane and all that affected, and then you can Burr cells and echinocytes. Okay, now one more thing, because of the blockage over here, there's going to be the increase 1,3-biphosphoglycerate is converted into increased 2,3-biphosphoglycerate. Okay, so what does it do? You have to go back to our oxygen dissociation curve. What happened to the oxygen dissociation curve? It shifted to the right, so the increased release of oxygen. So it's also clinically significant, and these people, even with the huge hemolysis picture, they might not be symptomatic because oxygen is released and they don't feel shortness of breath and all that. Remember that, okay? Now let's look at our diagnostic. So you have normal MCV in these people. Everybody know that, right? Decrease hemoglobin and decrease HCT, again, it's an anemia, hemolytic anemia. Then you have hemolyzed picture. Somebody tell me, like, what is hemolyzed picture?
So it's increased LDH,
Increase LDH and decrease haptoglobin.
haptoglobin.
Okay.
Increase unconjugated bilirubin.
Unconjugated bilirubin. Okay. And then, of course, you got reticulocyte count is also affected. Okay. Peripheral smear. Read that really loud. What is it?
Burr cells, echinocytes.
Okay. Very, very important, right? And then, of course, you have pyruvate kinase, you can check the enzymatic activity of pyruvate kinase, you can check. And then you can also check for PKLR gene mutation. We already said that is the main defect also. And how do you treat it? Mainly, you have like treatment, okay? What is the treatment? Of course, I mean, anemia, you do a transfusion, and in neonatal, there's like a role for phototherapy, and then there's a new drug just approved by FDA in February 2022. That is called, what is that? Mitapivat. Okay, the mechanism of action is an oral allosteric activator of RBC pyruvate kinase. Okay, oral allosteric activator. RBC pyruvate kinase. So this is a new drug, just came into the market. So remember, you need to remember this, mitapivat. And then, of course, because of the hemolysis, you got like decreased folic acid, so give folic acid supplementation. Splenectomy also has a role in it. Make sure when you do splenectomy, vaccination against what? Encapsulated organism, right? Which one? Pneumococcal and H. influenza and Neisseria. Those are the things you have to do for treatment. Again, just going back, let's go back and look at the main picture. It's an intrinsic defect, it's an enzymatic defect, right? And then extravascular hemolysis in the spleen, and then you got PKLR gene mutation, you got neonatal childhood adolescent. You mainly have the hemolysis picture. Remember, in pregnancy it can go crazy, and sometimes the diagnosis could be made in the pregnancy place also, and all the other clinical pictures. So hemolysis, jaundice, you got splenomegaly, and the pigmented gallstones. Okay, the main thing is you have to know this biochemical pathway. It's very, very important. You got glucose 6-phosphate, fructose 6-phosphate, fructose 1,6-biphosphonate, glyceraldehyde 3-phosphate, 1,3-biphosphoglycerate, 3-phosphoglycerate, 2-phosphoglycerate, phosphoenol pyruvate, and then you got pyruvate. The main thing is right here, right? This pyruvate, phosphoenol pyruvate to convert into pyruvate. And what do we need? Pyruvate kinase. This enzyme is the one affected, right? So what happened? ADP will now be converted into ATP. And who needs ATP? RBC needs it, because the sodium and potassium ATPases need to create the cell membrane in shape, and you can have, what is this called? Burr cells or echinocytes. Okay, and then always remember the hemolysis picture, and then Burr cells or echinocytes. If an examination question, sometimes they can put the picture of that. And then treatment, again, mitapivat, right? What is mitapivat again? Somebody tell me.
It's an allosteric activator of RBC
pyruvate kinase. Okay, oral allosteric activator of RBC pyruvate kinase. Remember that. Okay, and then of course remember about folic acid supplementation, splenectomy, and make sure when you have splenectomy, you vaccinate to protect against the encapsulated organism. Thank you so much for everyone watching. Please subscribe to our channel. It will be very helpful because it takes a lot of effort from a lot of people in this group to come up with the presentation like this again. Once again, thank you so much.